Neal, we've heard from Dan and Brian about how they are currently managing their cancer patients, their evaluation. Can you tell us a little bit about how your practice, and I know that you are obviously very, very involved in the early identification, monitoring of these patients. Tell us a little bit about your thoughts on early identification, monitoring, and how these CRPC patients need to be managed moving forward, whether it be by the urologist or in a multidisciplinary approach.
Okay, so two really good questions. One's about what's a strategy for monitoring, and then who's going to manage these patients. In terms of monitoring, there are a lot of different ways to go about doing this. One of the things in larger groups that we've talked about, and we recently had a course at the Large Urology Group Practice Association National Meeting on MCRPC, what we're talking about right now. And we had one of our panel discussions was on setting up a prostate cancer clinic, specifically an ADT, androgen deprivation therapy / bone health clinic. Now, one of the things I think that's great about a clinic like that is, number one, it helps you look at all of the adverse events that we inflict upon our patients with ADT, whether it's bone demineralization and the risk of fracture, central obesity, weight gain, cognitive impairment, adverse lipid profile. But most importantly, it allows us to do better monitoring of those and then offer treatment strategies to mitigate some of these side effects. So when you set up a bone health clinic like that, so you can check vitamin D and calcium levels and the importance of giving it, but you also have a very nice data mining opportunity so that you're following your patients closely when they convert from being androgen sensitive to castrate resistant. And this defining line is so important because if once we understand early on the patients who have been androgen sensitive to their androgen deprivation therapy, regardless of the LHRH agonist or antagonist that you've chosen, eventually those patients, virtually 95% of them, will start to have a rising PSA despite a castrate level of testosterone or a T level less than 50, unless they die of something else, unfortunately. So the PSA starts to rise, and immediately we can identify these patients in our clinics or individually as clinicians that they are CRPC. And the Prostate Cancer Working Group has said that a patient is CRPC based upon 2 or 3 successive rises in PSA, taken at least 1 to 2 weeks apart, rises from their nadir, their lowest point after starting ADT. And then if we get a bone scan or a CAT scan or an MRI or a PET scan, regardless of the radiographic diagnostic modality, if it's negative, but the PSA is going up, then they're M0 CRPC. So right now, we don't have an approved therapy for M0 CRPC. We're sort of in this wasteland of uncertainty as to what to do, other than the unapproved second-line hormonal manipulations, which we do. Add an anti-androgen, withdraw an anti-androgen, switch it, add an estrogen or ketoconazole. None of those strategies have been shown to improve survival or delay progression. They can impact PSA. But the idea of having a clinic run by a mid-level, a nurse practitioner or a physician assistant, or even one of the physicians within your group, is a way to make sure that all of your partners are carefully monitoring this very important transition from androgen sensitive to castrate resistant. And then the question is, well, how often do you order scans? And we don't have a perfect answer to this. The AUA Guidelines Committee is meeting currently right now to help us with their guideline suggestions and recommendations. Of course, one still has the benefit of recognizing that advanced prostate cancer and medicine is a combination of both art and science. So we have to look at the individual patient. We have to look at many different parameters. The age of the patient's comorbidities, and what we evaluate in terms of the pace of the disease, PSA kinetics, PSA doubling time, absolute PSA, to help and assist us in deciding how often to scan patients. There's no point in scanning a patient, creating undue cost, undue anxiety, unnecessary radiation exposure, if you're not going to have something actionable to do. But now we do, right? Because just a few years ago, we didn't have anything. If you were asymptomatic and had radiographic evidence of disease, almost no one was going to really offer docetaxel. In some situations we might have, and there would be benefit for it. I don't mean to completely denigrate that, but for the most part, the asymptomatic M1 CRPC patient, we didn't really want to know because we didn't have anything to offer them. Well, now we have immunotherapy. We're on the cusp of having an oral androgen biosynthesis inhibitor. And we may have many other therapies as well pretty soon. So we need to think a little more proactively about how frequently we scan. Maybe it's at baseline, once a patient converts from androgen sensitive to CRPC. And then maybe it's every 6 months, maybe it's once a year, maybe it's based upon PSA doubling time. One has to think what will work best for one's clinical practice. And that's typically my recommendations for my colleagues. Now, in terms of who should manage these patients, I think that, again, it's, like prostate cancer being a heterogeneous disease, the way we practice medicine in this country is quite heterogeneous, depending upon states, even within counties, and certainly regionally. Ideally, a multidisciplinary integrative approach is the gold standard, right? Having an expert medical oncologist, radiation oncologist, pathologist, nutritionist, physical therapist, and urologist. This is really the ideal setting. Unfortunately, we have a fair amount of fragmentation in our healthcare system, and even in academic centers there's some fragmentation as well in terms of proximity of clinics. But I think the academic model of multidisciplinary care is one that we need to strive for within the community. I think we are moving in that direction. How you get there is, there are different pathways. So if you're in an intermediate size practice of 5 or 10 urologists, one can have a member of your group really focus on advanced cancer therapies. Not everybody needs to be the robotic surgeon. That would be foolhardy. It wouldn't be a good use of your services. Not everybody needs to be a prolapse repair expert. Not everybody needs to be a prosthesis erectile dysfunction expert. You probably only need 1 or 2 in a large group. Complicated stone therapy, pelvic pain therapies. Not everyone needs to do it, nor can they. And similarly with advanced prostate cancer, it's my strong belief that you only need 1 or 2 dedicated physicians within the group to really commit the time and the interest to understanding the systemic therapies. And through internal referrals and subspecialization, you can really have a true center of excellence and provide great services to your patient population, whether you're in Myrtle Beach, South Carolina, or in downtown Manhattan. I think this is the way to go. We're learning so much. Urologic, oncologic care, like all aspects of medicine, is getting much more complicated. Fortunately so, we're learning so much more with proteomics and genomic understanding of pathways. So there is a way to get there. You can do it by subspecializing within your group. You can do it by having multidisciplinary panels with your local referring medical oncologist, nuclear radiologist, radiation oncologist. It really is based upon your own particular parameters. Communication, education, and dedication are, first and foremost to making it successful. So how you get there, there are many different pathways. At the end of the day, it has to be creating a center of excellence and providing an opportunity for patients to at least have a discussion. This is very important, that they have an opportunity to have a discussion of all the approved therapeutics, and that they're not pigeonholed based upon any one clinician's favoring or education on any one particular therapy or intervention.